Hi and hello everyone. Here we have Dr. Shivam Arora sir, MD General Medicine from MAMC New Delhi to teach us about ECG, who's going to make ECG really easy for us. So over to you, sir.
Thank you. Hello everyone. Today we'll continue our discussion on basics of ECGs and we'll discuss today about ECG in SA and AV nodal dysfunctions. Okay. So let us first start with AV nodal dysfunctions or AV blocks. So we have three types of AV block. First one is first degree AV block, then we have second degree AV block, then we have third degree AV block. Out of these, second degree AV block is divided into three. Mobitz type 1 block, then Mobitz type 2 block, and we have advanced block. Clear? Now we have another classification of AV block. That is suprahisian block or nodal block, and second one is infrahisian block or infranodal block. So it is classified as, we have this AV node here, then we have bundle of His below the AV node. Okay. Then this bundle of His divides into right bundle branch and left bundle branch, and left bundle branch further divides into left anterior and left posterior fascia. So if block is at the level of AV node, this is known as nodal or suprahisian block. If block is at the level of bundle of His here or below the level of bundle of His at the levels of bundle branches or fascicles, this is known as infrahisian or infranodal block. So the basis of dividing the AV blocks into these types is that infrahisian blocks are below the level of AV node. So they have poor prognosis. Reason being, first reason is, since they are below the level of AV node, so the escape rhythm in them would be ventricular. Clear? And second thing is that the infrahisian blocks do not respond to atrophy. No response to atrophy. Third thing is they are usually irreversible. Clear? So why they don't respond to atropine is, we have muscarinic receptors on SA node, AV node, atrium muscles, but we don't have muscarinic receptors on ventricular musculature. Clear? Since we don't have muscarinic receptors on ventricular musculature, that's why atropine doesn't act on infranodal blocks. Okay? So mostly the infranodal or infrahisian blocks are have ventricular escape rhythm. So most of the time the patient is hemodynamically unstable in them. So they are more dangerous, and also they don't respond to atropine. Clear? Now first degree AV block. So in first degree AV block, it is the simplest type of AV block. Okay. How we diagnose it is that there is no skip QRS. Means every P wave is followed by a QRS wave. The only difference is our normal PR interval is 0.12 to 0.2 seconds. It is less than 5 small squares. Clear? So if this PR interval is more than 0.2 seconds or more than 5 small squares, this is prolonged PR interval. So in first degree AV block, we only have this prolonged PR interval, but there is no skip QRS. This is called as first degree AV block. Now the causes are mostly we have reversible causes for first degree AV block, like beta blockers can cause first degree AV block. CCBs can cause first degree AV block. Digoxin can cause first degree AV blocks. Electrolyte abnormalities can cause first degree AV block. In irreversible causes, we have this AV nodal dysfunction, which can be because of fibrosis, ischemia, infarct. Clear? Now, first degree AV block is mostly at the level of AV node. Clear? So most of the time, first degree AV block is a nodal block. So it is a AV nodal block, or we can call it as suprahisian block. Clear? So it would be having a good prognosis because it is a suprahisian block and it will respond to atrophy. Clear? Now we have this second degree AV block. In second degree AV block, we have skip QRSs. That is the difference between first degree and second degree AV block. In second degree AV block, every P wave is not followed by QRS. So we have this P wave QRS, sorry. We have this P wave and QRS, then P wave, then QRS, and P wave and no QRS. Okay. So this can occur in any ratio. So there would be skip QRS in each type of second degree AV block. Now we have these three types of second degree AV blocks. First is type 1, Mobitz type 1 block. What happened in this Mobitz type 1 block is there is P wave, PR interval, QRST, and again P wave. This time QRS segment, QRS complex occurs somewhat late. So there is progressive prolongation of this PR interval, and then there is a skip QRS. Okay. So in this, there is progressive PR prolongation followed by a skip QRS. This phenomena is known as Van Quebec phenomenon. Okay. So this is known as Van Quebec phenomena, or we can call it as group beating. Clear? So we can see here that this PR interval is somewhat shorter. Then we have this second PR interval, which is longer than the previous one. Then we have this PR interval, which is more longer than the previous one. And then we have this P wave and no QRS here. And again, the cycle repeats. So this is second degree AV block Mobitz type 1, which is also known as Van Quebec phenomena or group beating. So in second degree AV block, since there are skip QRSs, we have to tell the conductance ratio in them. So suppose this is one cycle and this cycle keeps on repeating. We have one P wave, two P wave, three P wave, and fourth P wave here. Clear? So we have four P waves and 1, 2, 3, three QRSs. We have four P waves and three QRSs in every cycle. So this time the conductance ratio is 4:3. Okay. So for every 4 P waves, we have 3 QRSs. Suppose there would be 5 P waves and 4 QRSs, then the ratio would be 5:4. So this is how we can tell the conductance ratio. Another important thing about Mobitz type 1 block is most of the time it is at the level of AV node. So again, it is a type of nodal or suprahisian. Okay. So this would be having good prognosis. And second thing is it will respond to atropine, and it can be reversible. Okay. And what are the causes of Mobitz type 1 block? Reversible, we can have reversible causes like electrolytes abnormalities, and then we have in reversible causes we have inferior wall MI. So inferior wall MI can cause AV nodal blockage at the level of AV node. So the AV block due to inferior wall MI is having a good prognosis, and it is mostly reversible. Clear? And then we can have irreversible causes like AV nodal fibrosis or conduction tract fibrosis. Clear? Then we have this second degree AV block Mobitz type 2. Clear? In this, there are skip QRSs, but PR interval remains constant. Clear? So in Mobitz type 1, there is progressive PR prolongation followed by a skip QRS, but in Mobitz type 2, we have PR interval that is constant and there are skip QRS at regular interval. Okay. So in this we can see that this PR interval is constant, this is same, and these are same. Okay. Now in this too we have to tell the conductance ratio. So in this there is this one P wave, second P wave, and third P wave in each cycle, and one QRS, two QRS in each cycle. So this is a 3:2 second degree AV block. It can be 4:3 again. It can be 5:4. Another thing about second degree Mobitz type 2 block is it is mostly infranodal, or we can say that it is mostly infrahisian. Okay. So it is generally having a poor prognosis. Yeah. Another thing is it is mostly associated with anterior wall MI, and it is usually irreversible. So in Mobitz type 2 second degree AV block, the treatment is permanent pacemaker. Clear? Then we have third type of second degree AV block, that is advanced AV block. Clear? So in advanced AV block, you can see this advanced AV. It's a type of second AV block. Okay. So what happened in advanced AV block is that we cannot tell that either it is Mobitz type 1 or 2. Why? Because we don't have any PR interval to compare. Because in advanced, in normal second degree AV block, we have in each cycle, we have like more P waves to compare. While in advanced AV block second degree, we don't have more PR interval to compare. Suppose this is a P wave, then this is QRS, then T, then another P wave, and there is this skip QRS, then P wave, QRS, T, another P wave, and skip QRS. Okay. So this would be a 2:1 AV block. We have this 2 P wave in each cycle and 1 QRS in each cycle. There. So this would be a 2:1 AV block, definitely, but we cannot tell that either it is a Mobitz type 1 or Mobitz type 2 block. Why? Because we don't have PR interval to compare. So like this is one cycle. This cycle we have only one PR interval. And second time there is no QRS complex, so there is no PR interval. So in each cycle we have this one PR interval, so we cannot compare with another one. So definitely we cannot tell that it is a Mobitz type 1 block or Mobitz type 2 block. So in that condition we call it as 2:1 AV block or advanced AV block. Similarly, suppose we have this one P wave and skip QRS, then second P wave and skip QRS, then third P wave QRS, and again P wave no QRS, P wave no QRS. Here, so in this type we have in each cycle 3 P waves and 1 QRS. Here, so we cannot compare the PR interval here again. So this would be a 3:1 AV block. Here, this would be a 3:1 AV block or advanced AV. And in advanced AV block, we cannot tell that either it is a Mobitz type 1 or Mobitz type 2. But definitely, since in advanced AV block there are more QRS skips, so advanced AV block is having poor prognosis, and it is mostly irreversible. Clear? Then again we have this third degree AV block. This is also known as complete heart block. So basically in complete heart block, we have complete shutdown of connection between the atria and the ventricle. Clear? This can be at any level. This can be at the level of AV node, or at the level of bundle of his, or at the level of bundle branch. But there is complete shutdown. Clear? So what would happen that no P wave is followed by a QRS complex. So SI node would fire at its own rate, and there would be no QRS that is following a P wave. But yes, there would be a escape rhythm, which can be junctional escape rhythm in case of block at the level of AV node. Okay, so we have QRS in between, but there would be no relation between the P wave and the QRS complex. Okay, so there would be PP interval constancy and RR interval would be constant, but P and R don't have any relation. Okay? So this is known as AV dissociation. We can have P wave at a regular interval because of SI node firing, and QRS complex at regular interval because of AV node or junctional rhythm. Okay, or if the complete heart block is at the level of bundle of his or below that, then we can have ventricular escape rhythm. So if we would be having ventricular escape rhythm, again PP interval would be constant, RR interval would be constant, but there would be no relation between P wave and QRS complex. Okay, but the difference here is if the block is at the level of AV node, the escape rhythm would be a junctional rhythm and it can respond to atropine and it can be reverse. Clear? And most of the time patient is hemodynamically stable here. But if the block is below the level of AV node, the escape rhythm would be ventricular escape rhythm. The patient would be hemodynamically unstable and it is mostly irreversible. Here. Now in this ECG, we can see that this is a P wave. Here. This is a P wave. This is a P wave. Here, this is a P wave which is merged on T wave. This is a P wave. This is a and this is QRS. This is again QRS. Again QRS. Okay. So we can see that the PP interval is constant. Okay, and RR interval is constant, but there is no relationship between a P wave and a QRS complex. So this is a complete heart wave. We have first P wave here and second one would be somewhat merged in this QRS complex. And here also one P wave is merged in this QRS complex. So we can see that the PP interval is constant and RR interval is also constant. But there is no relation between the P wave and QRS complex. Here this QRS and this is the P wave. So this much long is the PR interval in this QRS and there is no P wave behind it. Then this QRS, okay. So we don't have any regular relationship between P wave and QRS complex. Now, since we know that AV nodal blockage can be suprahisian or infrahisian, and we know that this is having poor prognosis. And we also know that Mobitz type 2 and complete heart block, third degree AV block are mostly infrahisian, while first degree AV block and second degree Mobitz type 1 are mostly suprahisian. So if any patient is having AV nodal blockage and patient is hemodynamically unstable, okay, patient is in shock because of this, then the treatment is pacemaker insertion. Okay. But if the patient is hemodynamically stable, then we have to know that whether it is an infrahisian block or suprahisian block. Because if it is an infrahisian block, although the patient is hemodynamically stable now, he can anytime go into shock. So we have to get a pacemaker insertion in that case. But although we know that first degree AV block and second degree Mobitz type 1 block is a suprahisian block most of the time, but sometimes they can be infrahisian in 2 to 3% of the cases. Similarly, Mobitz type 2 block is mostly infrahisian block and complete heart block is also mostly infrahisian, but we can definitely have some of the cases where they are suprahisian. So in that case, it is very crucial for us to know that whether the block is infrahisian or suprahisian to get pacemaker insertion. So for that case, we use electrophysiological study to know whether the block is suprahisian or infrahisian, or we can also use this His bundle recording or His bundle electrogram. Okay. So what is His bundle electrogram? So His bundle electrogram is somewhat like this. We have this A complex because of atria depolarization. Then we have this H complex due to depolarization in His bundle. And then we have this V complex due to depolarization in ventricles. Yeah. Now suppose this is the ECG in which there is no QRS followed by a P wave. So now we have to know whether the block is at the level of AV node or below the level of AV. Okay. So if in that complex there would definitely be this A wave because of the atria depolarization, definitely it would be there. Okay. Now if there won't be having any H wave, so the block would be at the level of AV node. Clear? Since there is a skip QRS, there won't be any B wave here. Clear? Since we have this AV nodal blockage second degree, okay, so this QRS won't be there. This P wave is not followed by any QRS complex. So in His bundle electrogram, P wave won't be there, that is for sure. Now and A wave would be there, that is again for sure. So we have to see the H wave only. Okay. So if H wave would be there, means his bundle depolarization is occurring, which means the block is below the level of his bundle. Okay. And if H wave won't be there, then the block is above the level of his bundle, that is, it is a suprahisian block. Okay. So if we have this A wave and no H wave and no V wave, then we can say that it is a suprahisian block. If there is A wave, H wave and no V wave, we can say that it is an infrahisian. Clear? Again, we have this AH interval and HV interval in his bundle electrogram. So suppose a patient is having first degree AV block. Clear? So every P wave is followed by a QRS complex, that is for sure. So A complex would be there, H would be there, and V would be there. Okay. But there would be some delay. If AH interval prolongation is there, then first degree AV block is at the level of AV node. If HV interval prolongation is there, then the first degree AV block is infra node. Okay. So if AH interval prolonged, it's nodal. HV interval prolonged. Is it clear? So till now we have discussed about AV nodal dysfunction. Now we will discuss about this SA node dysfunction. So SA node dysfunction is also known as sick sinus syndrome. Here, for SA node dysfunction, again we have intrinsic causes and extrinsic causes. In extrinsic causes, we can have ischemia, electrolyte imbalances, drugs like beta blockers, CCVs. Okay. So for extrinsic causes, they are reversible mostly, and we have to look for reversible causes initially. But if we don't find any reversible causes, then the cause most likely is intrinsic, that is fibrosis of conduction pathway. Clear? Now, how to diagnose sick sinus syndrome, or what are the changes in ECG in patient of sick sinus syndrome, or you can say what are the arrhythmias that are associated with sick sinus syndrome. First thing that is associated with synodal dysfunction is inappropriate sinus bradycardia. So what happens in inappropriate sinus tachycardia is, suppose a patient is having heart rate of 45. Okay. So the reason may be there is SA node dysfunction, that is SA node is not working properly. Okay. So it is firing at a lower rate leading to bradycardia. And another cause may be because the person is an athlete or the patient is in resting state. So 45 heart rate may be normal for him. So if this person is doing exercise or running, then heart rate should definitely increase to compensate for the increased load. Okay. But if the patient is having resting bradycardia and also the heart rate doesn't increase when the requirement of the body is increased per se as in exercise or when the person is running, then this is known as inappropriate sinus bradycardia, or this phenomena is known as chronotropic incompetence. That is, SA node is firing at a lower rate in resting condition, and when the body's requirement increases, and in that condition when the heart rate should increase, the heart rate doesn't increase appropriately. So this is known as chronotropic incompetence. So it is one of the things that manifest in patient of sick sinus. Okay. Second thing we can have is sinus arrest, sinus pause, or SA exit blocks that we'll discuss in upcoming section. It's something very important. Then we can have tachycardia, bradycardia syndrome in patients of sick sinus syndrome where the SA node doesn't work. That we'll discuss in the next slide. Then SA node dysfunction would present as chronic AF. Why? Because suppose SA node is not working. So someone should take the work of the SA node. So if atria get hyper excited and they started firing and they take over the pacemaker function of the SA node, so it leads to atrial fibrillation. Okay. So in that case, since SA node is not working, the patient would be in chronic atrial fibrillation. Okay, just give me a minute. Okay, hello guys. So sorry for the inconvenience. So we were discussing that in patient of sick sinus syndrome, he would be having chronic AF. Why? Because since SA node is not firing, so someone should take the work of the SA node, and in most of the cases, atria take up the work of the SA node. So in that case, most of the time we have this chronic atrial fibrillation. Okay? And the most common arrhythmia in case of chronic atrial, in case of sick sinus syndrome is chronic atrial fibrillation also. Okay? Or if suppose atria doesn't take up the work and SA node is not firing, so in that case, sometimes AV node takes up the work and junction rhythm would present. So junction rhythm can be one of the presentation of sick sinus syndrome or SA nodal dysfunction. Or we can have ventricular rhythm if AV node doesn't take up the work, and in that case, ventricular rhythm would be the presentation of a SA nodal dysfunction. Or we can also have accelerated idioventricular rhythm as one of the presentation of sick sinus syndrome or SA nodal dysfunction. Okay? So these 5 points are very important. Like suppose if SA node doesn't firing, so someone should take up the work of the SA node. It can either be atria or AV nodes, or below AV node, bundle of which can take up the work, or ventricles can take up the work. Okay? So definitely in that case, we can think as SA node as one of the possibilities. Clear? Now let us move to the next slide. Okay. So we have this TACHY syndrome. This is also one of the presentation of sick sinus syndrome or SA nodal dysfunction. So how? Let us discuss. Suppose there is SA nodal dysfunction due to which there is sinus bradycardia. So we have already discussed that inappropriate sinus bradycardia is one of the presentation of SA nodal dysfunction. Okay. So sinus bradycardia is going on because of that SA nodal dysfunction. Clear? And suddenly SA node stops firing. In that case, suppose if atria take up the work of the SA node, then it would present as atrial fibrillation. Okay. So we can see that initially sinus bradycardia was going on in this ECG, and suddenly there is a pause. This pause represents that SA node stopped firing suddenly. And when SA node stopped firing suddenly, at one point, this atria take up the work and atrial fibrillation started. Okay, so we have this tachycardia as atrial fibrillation here. And again, when atrial fibrillation stopped, there is this sinus pause, and that SA node takes up the work. Okay, so again, SA node takes up the work, and again, bradycardia started. So this is basically known as tachy-Brady syndrome. And this is one of the important presentation of SA nodal dysfunction or sick sinus. Clear? And we have already discussed that the most common arrhythmia in case of sinus nodal dysfunction is atrial fibrillation. Clear? Now we have sinus pause and sinus arrest as a picture presentation of sinus node dysfunction. Okay, so what is the difference between sinus pause and sinus arrest? That is, suppose in this ECG we can see that P wave is there, QRS is there, T wave is there, and suddenly sinus node stop firing. And again sinus node, SA node takes up the work suddenly, and again it started. Okay, so this pause that comes up when the sinus node stop firing, this is known as sinus pause or sinus arrest. The basic difference between sinus pause and sinus arrest is just that in sinus pause, the straight line is less than 3 seconds, and in sinus arrest, the straight line is more than 3 seconds. That is, if SA node stopped firing for less than 3 seconds, then it is known as sinus pause. And if SA node stopped firing for more than 3 seconds, then it is known as sinus arrest. Okay, but basically they are the same thing. Only difference is between the duration. That is, if the duration is more than 3 seconds, then it is sinus arrest, and if duration is less than 3 seconds, then it is sinus pause. But both of them are the presentations of sinus node dysfunction only. Okay. Now SA exit blocks. Okay, so SA exit blocks are also the presentation of sinus node dysfunctions, and we have three type of SA exit blocks. They are same as AV nodal blocks. Okay, so we have first degree SA exit block, second degree SA exit block, third degree SA exit. And again, as in AV node, the second degree SA exit block is of two types, that is type 1 and type 2. Yeah. So what is first degree SA exit block? So basically in first degree SA exit block, there would be delay in firing of the SA node. Clear? So similarly, this is first degree AV block. Okay. What happened in first degree AV block is that AV node slows down, but every impulse would be conducted. Okay. So there is prolonged PR interval. Clear? And every impulse would be conducted. That is first degree AV block. Similarly, in first degree SA block, this is SA node, this is atria. Okay. So SA node would definitely depolarize atria every time. So definitely there won't be any skip beat. But SA node slows it firing. Okay. Since SA node would slow it firing, first degree SA exit block would present as sinus bradycardia. So definitely on ECG, we cannot diagnose first degree SA exit block because we can have 100 of causes of sinus bradycardia. Okay. One of the cause is first degree SA exit block. Okay. Now we have this second degree SA exit block. So definitely similarly as occur in second degree AV block, there is one skip beat. Okay. Now in AV block, the skip beat is a QRS complex, while in SA exit block, the skip beat is a P wave. And since P wave would be absent, there won't be any QRS or T wave also. So suppose this is P wave, then QRS, then T, then P, then QRS, then T. And at this point, SA node didn't fire. Okay. So there won't be any P wave and not there won't be having any QRS, and there is not any T wave. Okay. And again this P QRST and P QRS. Okay. So this is SA exit block second. Yeah. And this gap here is a sinus pause. Clear? Now we have second degree SA exit block type 1 and type 2 that we'll discuss in the upcoming slide. And in third degree SA exit block, third degree AV block means that AV node is not allowing any impulse to pass through it. Similarly, in third degree SA exit block, SA node won't fire. Yeah. So since SA node won't fire, there won't be any S wave. Since there won't P wave, sorry. So since there won't be any P wave, and since P wave is absent, so anyone should take the work. Okay. Since SA node stop firing, so any other conducting system should take up the work of the pacemaker of the heart. Okay. So this can present as atrial fibrillation. Since SA node stops firing, atria takes up the work, or this can present as junctional rhythm, or this can present as ventricular rhythm, or this can present as accelerated ventricular rhythm, or this can present as focal atrial tachycardia. Clear? So again, third degree SA exit block cannot be diagnosed on ECG. Okay? So in ECG, third degree AV SA exit block presents as junctional rhythm or atrial fibrillation or ventricular rhythm. Clear? Again, the symptoms in these blocks would be syncopal attacks or lightheadedness. Why? Because as we can see in second degree SA exit block, there is the sinus pause. So at this time, there won't be any perfusion of the brain leading to syncopal attack or lightheadedness. Similarly, in X-ray exit third degree AV block, since SA node stops firing suddenly, there would be a pause or arrest, followed by any other conduction system taking up the work of the pacemaker. Clear? Now, SA exit block, second degree type 1 and 2. Okay. So, like in AV node block, second degree type 1, there is progressive prolongation of the PR interval, and which is followed by a skip QRS. Similarly, here, SA node would fire, another beat got a little late, then another a little late, and then the fourth one doesn't flow. So in SA exit block second degree type 1, we have progressive PR prolongation, or we can have progressive PR shortening followed by a skip complex. Okay, so we have this PQRST, 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 and this sinus pause where there is no P wave, no QRS complex, or no T wave. Okay, and in this there is PP interval shortening or PP interval lengthening, okay, which is followed by a skip PQRST or skip cardiac cycle, we can say. So this is second degree type 1 SA exit block. This is also known as Van-Quebec phenomena as in AV block. In second degree SA exit block type 2, similarly as in AV nodal block second degree type 2, there is no progressive delay, but yes, there is a skip complex. Similarly, here PP interval would be constant. Okay, but after some cycles, there is a skip P wave, which is followed by skip QRST. Okay. So a skip cardiac cycle, or this is known as sinus pause. So SA exit block type 1 and type 2 presents as AV nodal blockage second degree type 1 and type 2. This type 1 is having a Van-Quebec phenomena or group beating. Similarly, we call second degree AV nodal blockage type 1 as group beating or Van-Quebec phenomena. Okay. So this is all about SA nodal dysfunction. So today we have discussed about SA nodal and AV nodal dysfunction, and in upcoming sections we'll discuss more about arrhythmias. Okay. Thank you very much, and if you have any questions, then you can ask.
Thank you so much, sir. As of now, there's no doubts. So if participants have doubts, they can post the YouTube session comment box, and sir will be happy to answer you all. And thank you everyone who has joined us via Zoom and YouTube. And thank you so much, sir. Actually, you have made ECG easy for us. Thank you so much, sir. We are waiting for your upcoming session.